Hey team, welcome back to the Student Paramedic Podcast Paediatric Mini-Series. Hey team, welcome back to the Student Paramedic Podcast Paediatric Mini-Series. And this is episode 4, where we're following on from pediatric trauma to analgesia in kids. So it is generally a bit of a difficult one for us in pre-hospital, depending on what's available to us in terms of different services or different countries, wherever we may be. So today we're going to discuss this once again with Dr. Andy Tagg. Thank you so much, Andy, for joining in yet again and taking time out to help us out and get to know a little bit more about analgesia in the pediatric population.
You're welcome, Alex.
It's an absolute pleasure to have you yet again, Andy. So we'll kick today off, though, with the question of why is it so challenging and what are some of the barriers to giving pediatric analgesia?
I think one of the big challenges is actually just the simple fact of assessing pain in children, especially non-verbal children. It can be really tough. You know, if I stub my toe or stand on a piece of Lego, I'm going to scream and tell you it hurts and I'm going to do something about it. But a 2-year-old you can't really do that. You know, a 2-year-old can't rate their pain out of 10 and to give you a score. They've not even got enough life experience to tell you this is the worst pain in their life ever. And so we need to be going for some other markers. As we spoke about in our trauma episode, we think about some of those physiological changes in states such as that screaming, the crying, the inconsolability, as well as that sort of tachycardia as a response to pain. But we're going to get some more subtle signs in the way they're behaving, they're interacting with us. And often that's that degree of consolability. You've all seen kids in the playground that have run around like a hoon, fallen over, scratched the knee, and then only start screaming when they know someone is watching them. If they think that no one's watching, they're not going to scream away. And so we've got to think about kids don't lie, but they also do have a different type of pain response than you or I might have. And so what I'd like to use is really just a simple Wong-Baker faces score, that one of, the kid's got a big smiley face and happy versus the I've got a big frowny face and I'm crying and it's that snotty, bubbly tears coming out of my nose and around my eyes and I'm inconsolable. That's, big pain versus little pain. And so it's worth thinking about how you might assess a kid's pain. And so perhaps you can say to the child, if they're able to talk and you don't want to give them a number, is it 1 out of 10 and hold up your thumb? Or a 5 out, or a score of 5, just hold up your one hand, or a 10, the biggest pain possible, and hold up both your hands in front of them. And they can point to your fingers. Well, if you don't have any obvious way of measuring what's going on, it might be an easier way of getting them to tell you what the degree of pain is. So that's one problem, is how we actually assess pain in kids. The other challenge is, for some reason, we don't like to give analgesia to children because we're worried it may hide something, it may mask something. And there's some great studies looking at kids with appendicitis coming into hospital and doctors not wanting to give them decent, strong analgesia for fear it's going to hide the clinical signs. And I know that if I went into hospital with appendicitis, I sure as hell would like some decent analgesia rather than some simple paracetamol. So why don't we do the same for the children that we see?
I guess one of the concerns could also be that there might be a bit of fear around giving pediatric analgesia, particularly with, I guess, that small dose, because we're having to calculate weight-based calculations for these different drugs. In terms of assessing pain for kids, do you have a recommendation on which type to use? Because obviously we've got Wong-Baker faces, we've got the FLACC score. Would the FLACC score be something you'd recommend? I guess we see the Wong-Baker faces quite a lot. So what would be your recommendation there?
So I think, like any scoring system, use one and use it consistently and get to know it. The FLACC score is a great pain score, especially for those non-verbal children, looking at their faces, their limbs, their arms, and their crying, the consolability. It's a great score to use for those sort of preschool kids who you can't communicate with. And so what's quite nice to do is actually just have a lanyard, a little, laminated card with your FLACC score and your Wong-Baker faces on the other side, and keep it with you. And so you've got a sense of, pull it out of your pocket just on the way to a job so you know what you're dealing with. Because it's not the sort of scoring system that I can remember off the top of my head easily either.
Yeah, I really like that. That makes sense. It's very simple. Just obviously, if you're going to use one, use it really well. So that's fantastic. In regards to now, we've got a patient who's in pain. We've assessed them using whichever score that we want to use. Now we've got the option for different analgesia, and different services will have different analgesia, and there'll be different guidelines. So obviously making sure we follow those. But what different kinds of analgesia are available for our pediatric patients? And in your experience, what are sort of the pros and cons of using these different ones?
So any analgesia in children up to the age of around 12, we're going to use a weight-based approach. So really important to get a rough idea of the weight. You don't need to sit down and weigh the child. We want a rough idea of the weight of the child. And there's lots of formulas you can use, but the best way is just to ask the parents, because most parents know how much their child weighs, and that'll give you a sense of what's going on. In fact, what I tend to do is, even before I see a child, if I know what their age is, I'll work out roughly what I think their weight should be. And then I can do some calculations on the way to see them to figure out how much analgesia I'm going to give them. So once I've got a sense of their weight and the degree of pain they're in, I'm going to start preparing some analgesia. And that can range from some simple oral stuff to some top of the range intravenous or intranasal analgesia, depending what the degree of pain is. And I often use a multimodal approach. And so I'll start with something simple and oral, assuming that it's safe to give the child something oral. But I know that it's going to take 45 minutes to an hour for paracetamol to actually do anything. So if a child's got a deformed arm or their tibia's poking out of the skin of the leg, I'm going to need to do something that's going to work a lot more quickly than that. So for this simple pain, a child that's, got a minor burn, they've fallen off the monkey bars and they've hurt their wrist, they've got some simple abdominal pain, I'm probably just going to give them some oral analgesia if they haven't already had some. And I'm going to start with some paracetamol at 15 milligrams per kilogram and give them a one-off dose. The real contraindications that are only if they've just had some in the last hour, they're actively vomiting because it's not going to go in. But most children should be able to tolerate some paracetamol syrup. And, as much as I'd like to think that, an 8-year-old should be able to swallow a tablet, I want to make things easy for them. So I'm going to give them some Calpol or some paracetamol syrup, and that's the easiest way to get things in them. The alternative to that, if you have access to it, is a non-steroidal anti-inflammatory like ibuprofen, and you can give that at 10 milligrams per kilogram as your dose. And those two analgesics work synergistically to help relieve pain in a lot of children. And certainly in our pediatric emergency department, we'll try and give them analgesia at triage if they haven't had any already, and so that by the time they're seen by a doctor, or perhaps if there's a long transit time from house to hospital, then the analgesia will be kicking in and feel a lot more comfortable and also a lot less scared because they're not in pain.
That's really great. That's a fantastic overview and follows that sort of ladder approach, I guess, to giving simple analgesia first. Like you mentioned, though, if you've got that patient who's got an arm sort of hanging off, just to be a bit dramatic, but if we do have a patient who's got a lot more complex pain or just a significant amount more pain than what our simple analgesia can provide, what's the next step? Where do we go from here? What kind of options do we have now?
So I, again, want something that's rapid onset, and strong. And so often what we'll use is an inhalational analgesia in this case. And so there are a number of options available depending on where you work. You may want to use something like entonox or nitrous oxide. You may have access to methoxyflurane or green whistle, or you may be lucky enough to have access to an intranasal analgesia like intranasal fentanyl that we often use over here. A lot of ambulance services are used to using entonox, which is a great ultra short acting analgesic agent that works in a large number of children. One of the challenges is, though, that obviously as soon as you stop breathing it in, it stops working. And so it may be great to extricate someone from the scene and get them out into the back of the truck, but it's not the sort of thing that's going to be super effective for a long transfer time. A lot of the children I see who've had entonox have problems with it because it starts to make them feel really nauseated. And so if you're feeling a little queasy because of pain, and because you're in the back of a ambulance that's going to speeding through the streets of London, and you're tooting away on some nitrous, make sure you've got your M bag ready to go because someone is going to spew.
Yeah, that's a really interesting point in terms of the transport times. So, particularly those working in more rural or regional areas, they're going to have a lot longer to consider what kind of pain relief they want and how long the action is for, or I guess the duration, half-life, etc., is of all their medications and what kind of things they want to look out for. So that's really insightful. You've gone through the downsides, I guess, to entonox. What about methoxyflurane? Because I appreciate a lot of our listeners are from Australia, and that is something that they use quite often. So, what would be some of the downsides to that one?
So I love to use methoxyflurane over here. It's great for a patient-controlled analgesic. The patient is old enough to be able to hold the green whistle, can breathe away, and you titrate their own analgesic needs. Most of them don't get a nausea as a side effect. It doesn't seem to cause any drowsiness that I've noticed. I think the biggest thing, actually, the side effects I've seen more than anything else is that sort of headache that children and adults may get. And so if you're in the back of the truck and you don't have the carbon filter, you may get a headache going if you're traveling along with the kids. Again, it's short acting, but it's great for short, painful procedures. So we often use it for shoulder reductions or reductions of dislocated joints in the emergency department. It's great for burns dressings or, moving people who've fallen over and have got, nasty limb injuries who need to get some analgesia on board with pretty minimal side effects.
Yeah, those are some fantastic points. I guess I trained in Australia, so I got to see the effects of methoxyflurane on patients, and I found its ease of use far superior compared to entonox, just due to the fact that it didn't really require a whole lot of educating to patients, and it was just really easy for them to breathe it in. Versus now in the UK using entonox, it's a lot harder for a lot of our patients to really get the desired effect from it. So for some of our patients, if they're agitated because of the pain, if they have sort of a decreased respiratory effort in terms of like they're not able to really breathe in very well, so particularly some of our elderly population might not be able to effectively use the medication. And even trying to coach like pediatric patients to use it can be quite a challenge. So I definitely found that the effects of methoxyflurane were really beneficial, particularly for, I guess, the widespread patient populations. So now that we've given our inhalation analgesia, what kind of stronger pain relief do we have available to us to give our pediatric population?
So I think it's important to recognize that broken limbs hurt, and every jiggle and wriggle of the truck as it goes over a bump, it can potentially hurt. So whilst they've got some decent analgesia on board, now's the time to apply whatever splint you want, whether it's a box splint or your CT6 or your Thompson splint. That's a great time to immobilize that arm or that leg just to reduce the amount of pain, because stopping it moving around is a great analgesic in itself. And it's one of the things that we do pretty badly in the emergency department, to be honest, compared to the pre-hospital. In that, we see a kid with an obviously deformed arm, they're just sitting there and they're waiting and holding on to it, waiting to come in. When really, it's a perfect time to even just putting on a broad arm sling or triangular bandage is a great way of just stopping the pain. Once we've got that, splinting in place, then we might want to go for a longer acting analgesic agent, depending on what's going on. And certainly in the hospital system, we might use oral opiates, IV opiates, or intranasal opiates. Most services don't have access to oral opiates, and obviously giving IV morphine can be a challenge in children just because it's the need to cannulate them, because it's not a great medication to give intramuscularly. And the alternative approach then is intranasal medication, which we use a lot of in Australia. Intranasal fentanyl is my go-to analgesic for short painful procedures, and it gives a chance then for oral analgesia to start kicking in.
Absolutely. Do you want to go into a bit more depth in terms of the intranasal fentanyl? Because I'm aware that quite a lot of services, particularly in Australia, do use it. I think there's some fantastic benefits to using it. And for those that don't have it, who are listening in, whichever service they work for and things like that, sort of so they can hear sort of the differences and potentially one day maybe drive for change in that sort of area.
So we use intranasal fentanyl, which is undiluted, a dose at 1.5 micrograms per kilogram. And we give it through something called a mucosal atomizer device. Essentially, it's something that fits onto the end of the syringe that turns that fentanyl into a fine mist that goes up the nostril. And we spray half it up one nostril and half up the other, and it's rapidly absorbed by the nasal mucosa and crosses the blood-brain barrier within 45 seconds to a minute, providing amazing analgesia with minimal side effects. It doesn't tend to cause nausea like a lot of opiates, and it doesn't really cause drowsiness. And so we use it on a daily basis to help relieve pain. It's limited a little bit by the weight of the child. If I'm giving 1.5 mics per kilo, I'm not going to give 2 or 3 mils of intranasal fentanyl up each nostril because it's just going to pour straight back out again. It requires a degree of coordination from the child because what we try and do is occlude one nostril while they have a good sniff up the other side, and we spray up as we go, and that seems to do the trick. And for those short painful procedures, getting foreign bodies out of legs, there's kids that have fallen onto things. It's a great thing to use for kids who've been burnt and have had clothing burnt onto them, and then we need to remove that clothing. It's a great analgesic to use, and you can use it when they're lying down, sitting up. It makes no odds. It's certainly a wonderful drug, and certainly something that I'm thankful for on a daily basis.
Absolutely. I've had the benefit of being able to use it and see it being used on placements as a student, and then coming over to the UK, we don't have that, and it's quite a challenge actually in terms of analgesia for kids. We're quite limited. We mentioned initially that IV morphine is available. IV access is incredibly, I guess. I think it would be one of those things that not many people try to do in the pre-hospital environment. I definitely don't see many sort of yellow and blue cannulas being pulled out and cannulating kids very often. Why are we so scared, I guess, of cannulating kids? And do you have any sort of tips and tricks to overcome any of those barriers?
So we could do an entire podcast on how tips and tricks for cannulating kids. I think the reason we're scared is because we don't like to cause pain to children. Veins in most adults are relatively easy to find and on the surface. And if you miss, actually most of the time you don't mind just giving another go. Whereas children are wriggly, they're often got a large amount of subcutaneous fat, so the veins are harder to see. And when you miss, kids will let you know. They'll scream and shout, and you often seem to be making things worse rather than better. And so often you think, well, maybe they're not in that much pain after all. Maybe I don't have to cannulate them. Maybe I'll just leave it alone for someone else to do. And so if the veins are straightforward and easy to see, then great. It's well worth chucking a blue or a yellow cannula in. Ideally, at least a blue cannula because they're a bit thicker and a bit longer and they're less likely to extravasate analgesia. And, to give something, but in hospital we often have the luxury of time, and we'll put Emla or local anesthetic cream on these kids to reduce the fear and the pain that they might have from cannulation. That's something you don't have the luxury of doing in the pre-hospital setting. We have the ability to use distraction therapy, whether that's using virtual reality or play therapists or mobile phones, to distract kids when we're putting cannulas in it. So it makes it easier to see. Again, something you often don't have the luxury out of doing in the pre-hospital setting. And the other thing we have is often have space and light so we can see things and we can control the environment to be able to do exactly what we need to do. And generally we want to do make our first attempt our best attempt. And certainly if that critically unwell child that needs cannulation, then you're just going to crack on and give it a go. But if it's a toss-up between, well, do they really need it? Am I going to miss it? This is their one arm because I can use because their other arm is broken. Shall I bother? Most people are going to actually just say, actually, I'm just going to wait and leave it.
You brought up some really fantastic points there, in particular one of those being the non-pharmacological methods of analgesia. What non-pharmacological methods do you normally have in your toolkit? Because I'm letting you know now, my glove animal making ability is shocking. So I need your insight into what sort of non-pharmacological methods you really draw on in times of need.
Yeah, so I guess with those distraction techniques, it's like in making your elephants and your dogs out of gloves. It's great. I used to find drawing on tongue depressors was really nice to make finger puppets out of those. But more than anything else, it's just spending time talking to children. I think most of us have that best distraction technique in our pockets these days. That's the mobile phone, and pick up an age-appropriate channel on YouTube and find an episode of Bluey for them to watch, or Roblox videos, or as some kids I've seen want to watch MMA fights, and that's a great distraction. Whatever floats their boat, if it's going to stop them looking at their dislocated ankle and it's going to make them feel a lot more comfortable, then that would be my go-to. Try and use the parent's mobile phone, not yours, because you'll never get it back otherwise.
Absolutely, and your YouTube will be all about Peppa Pig and Bluey, and yeah, that's it.
Exactly.
So we've gone through quite a wide range of sort of topics about analgesia, sort of the challenges, assessing, so using different kinds of modes of assessing it, the different types of analgesia available, and going through that sort of ladder kind of approach and working our way up. We've gone through sort of some of the IV access barriers and tips and tricks, and I guess the non-pharmacological methods as well. Is there anything we're missing?
I think the most important thing is to not discount this non-pharmacological techniques. A low, slow, calm voice is almost as effective as any medication you could ever give. And that also involves getting the parent or carer on side. And I think that's one thing we haven't really mentioned, is using those as an adjunct to anything you're going to do. Parents can be a great distraction. They can make sure the kid's not looking at wherever their injury is. They can hold the mobile phone, get them involved in what's going on. Explain to the carer or parent that's with them that you're going to give some analgesia. It's going to take some time to work, but it will work. Because what you don't want is getting that mum or dad getting amped up saying, oh, they need some painkillers. It's not working. Because the child's just going to feed on that anxiety. And so if you can set expectations early, use a calm, controlled voice, get the parent or carer on side, then it's going to make it a lot easier to deal with the child.
Absolutely, that's a fantastic piece of advice. So we've completed our analgesia in pediatrics episode of this deep dive. So thank you very much, Andy, for jumping on and joining us on this journey. And to all our listeners, hopefully you've learned something so far. The next episode will be grief and debrief for difficult pediatric jobs. So we'll catch you in the next one next week. Thank you very much.
Thanks very much, Alex.
Thanks for listening to this episode of the Student Paramedic Podcast, Paediatric Mini-Series. If you want to reach out to us, please email us at thestudentparamedicpodcast@gmail.com or find us on Instagram and Facebook. We will get back to you as soon as we can, and we'd love to hear your ideas for any future content.